Thanks for joining us.
Thank you. Happy to be here.
So going back, looking at this study, it's now going on 15 years in publication. What was some of the impetus for this study? What brought you guys to look at this?
Well, I think historically, the treatment of tibial plateaus as a kind of combined soft tissue and bony injury has been a little variable. So clearly, early treatment focused on the bony injury, hence led to the Schatzer classification and others. But as techniques and kind of insight into these injuries evolved, people started doing things like a submeniscal arthrotomy to look at the lateral articular surface, but then also noticed, oh, wow, the lateral meniscus actually torn a lot. And then a few centers kind of championed doing arthroscopy and noticed also mainly for articular reduction assessment, but also noticed, oh, this patient has a little ACL, looks to be a partial tear, or postoperatively, the patient's got a little valgus laxity. And so there's clearly more going on here. We really don't have a standard way a protocol to diagnose these soft tissue injuries. We don't really have a good sense of the incidence of how often some of the kind of structural soft tissues around the knee are injured in association with soft tissue or with tibial plateau fractures.
So briefly then summarize what you guys found in the study then.
So there were a few main take-home findings, I think. So first of all, I think it's helpful to see in about 100 patients, 60 of these, all comers, 62%, I think, were Schatzker-2s. So, it tells us the majority are these kind of lateral split depression type. In those Schatzker-2 type fractures, there's a high incidence of lateral structure, particularly meniscus pathology. Also, interestingly, looking at these MRIs where you could see a lot of less displaced fracture lines, there was never a true Schatzker-3 fracture, which is the kind of pure depression without some sort of fracture in the wall. So kind of disproved the notion of a pure Schatzker-3 fracture. And then really big picture, so you see this table 1 here of all the injuries, and you just scan down the percentages and just extremely high. So very high incidence of. Now it's important to remember when we talk about soft tissue injuries, it's really important to remember these are MRI. This is MRI signal, and we had a very senior musculoskeletal MR radiologist grade these, but certainly MR is known to be maybe oversensitive for kind of structurally important injuries. But anyway, at least as far as MRI signal went, just a very high incidence of injuries to soft tissues around the knee in general.
Great. And then how did this study then change your practice as you did this as a resident and then moved into fellowship and then into practice? And then I had the privilege of training with you as a resident. How did this change how you approached the tibial plateau fractures that came in to see you?
Yeah, so it's interesting. It really, I guess, it did and still does kind of affect my heightened awareness for the potential for destabilizing soft tissue injuries. When I first started practicing, I kind of tried to get MRIs on most of these patients. And I think the time and the place where this study was done in the mid-2000s in Manhattan was different than a lot of other times and places in the country. And it's really, especially in today's kind of value-based healthcare culture and climate, it's really not feasible or warranted, I don't think, to obtain an MRI in every tibial plateau fracture. So it did not change my practice to get an MRI in every tibial plateau fracture. But it really made me more closely examine the soft tissue structures, particularly intraoperatively, once the ORIF component was completed, because it's not, I would say, obvious or routine that we would do a full knee ligamentous exam, for example, on every tibial plateau fracture. And interestingly, as I would kind of thoroughly examine these after fixing a plateau fracture, I didn't find a lot of clinically, at least detectable to my exam, clear ligamentous injuries. And certainly there are some. And I think it's important to recognize intraoperatively so that you can do something at that time. Sometimes it's even put on an external fixator or leave on an external fixator. But it also demonstrated to me that probably these MRI findings of MR signal, example of like here on this, it's like popliteofibular ligament tear, posterolateral corner injuries, 50% incidence of rupture, but this didn't lead to clinical problems that we were seeing. And similar to a lot of these things that we kind of called everything partial PCL tear. So the problem is, what do you do with this information? And so it helped heighten my awareness, but it didn't really change my approach to detection, which remained really clinical diagnosis, either intraoperatively or by patient symptoms subsequently, feel, sensations of knee rotatory instability or laxity or anything like that. And we just don't see that often. And, I think the main reason for that is when we have a tibial plateau fracture, particularly the more severe type, there's a large inflammatory response, there's a large hemarthrosis. We're fighting stiffness, through the postoperative course. So these patients really tend to be stiff. And so I think some of these partial tears, like, PCLs and posterolateral corners, even MCLs, they don't result in frank instability or laxity of the knee, once the recovery is complete.
So with the findings of this study and maybe some of the other literature that's come out, for certain fracture patterns, will you always make a submeniscal arthrotomy?
Yeah. So absolutely. So I think it's warranted to do a submeniscal arthrotomy in pretty much every tibial plateau fracture with kind of clear intra-articular lateral sided involvement. I think so in the kind of Schatzker 2 or any pattern that has an associated split depression on the lateral side, you're kind of obligated to examine the lateral meniscus. It's very commonly avulsed from the lateral capsule. We wrote another paper, I think the subsequent year, kind of correlating the distance of displacement of the lateral wall, and the further it was displaced, probably somewhat intuitively, the higher the incidence of lateral meniscus tear. So I think you're obligated to do submeniscal arthrotomy. The other pattern is what kind of falls best under the Schatzker 4, but a fracture dislocation of the medial side where the majority of the lateral tibial plateau is intact and the lateral wall is intact. So if you were to do an anterolateral approach, you wouldn't find a clear fracture line to get into the joint. But the whole lateral plateau has displaced from under the distal femur, and it almost always has avulsed the lateral meniscus, which is often punched down into the kind of the central lateral plateau. So that's another one where you wouldn't go to the lateral side necessarily for the articular injury, but the lateral meniscus is almost always torn. So yeah, the submeniscal arthrotomy is one. I think of valgus stress. Another kind of soft tissue issue is, the mechanical concept that in order to have a valgus load on a knee that leads to lateral impaction requires an intact medial side as a hinge or a fulcrum. And we found that that's not true. So you can absolutely have a lateral plateau fracture and MCL laxity. And so again, we don't always treat that with direct MCL repair, but I think it helps counsel the patient. Maybe you use a brace afterwards. So I always do kind of a varus and valgus stress really for the ligaments post-operatively.
Great. Do you think there's anything that you guys would do differently if you were to redesign the study today?
Yeah, I mean, I think, we fought with the reviewers a little bit. and kind of rightfully so from their perspective on the clinical correlation of all of these findings, similar to what I've kind of mentioned earlier. But I think the real deficiency of the conclusions is that there's no clinical outcomes, and what the natural history of these MRI findings is clinically, we don't know that. And again, our sense is it's not nearly as severe as these high percentages might indicate. So I think to be a little more clinically useful from a study design perspective, we might have followed these patients clinically and see if they have any relevant ligament injuries.
Great. Something that not only find clinically relevant for certain fracture patterns to be aware of the soft tissue injuries, but it's also commonly tested on in trainings and board exams and things like that too. So really appreciate you joining us today.
Totally, no problem. Thank you.